Good morning. Thank you for joining us today. I am Melissa Silva, the Executive Director for the Mental Health Association for Greater Baton Rouge, the Louisiana affiliate for the Mental Health of America. MHA has served the Baton Rouge area and our state of Louisiana for over 66 years. MHA has partnered with the Louisiana Department of Health, Office of Behavioral Health, to offer behavioral health 911 events. These events offer education on topics affecting all of us in our state. As an advocate to those with behavioral health needs, today we're bringing you experts in the field speaking on topics specific and critical to your region. While we cannot be face-to-face to have these conversations, we do feel the need for them continues. There will be a time for questions and answers from our panel at the end of the conversation. Please enter your questions in the Q&A section. This is separate from the chat box. Today we are partnering with Avenues Recovery Center to bring you mental health and relapse and addiction. We would like to thank today's speakers for giving of their time and their expertise. Please enjoy the presentation.
Hi guys, I'm so grateful to be here today, to be a part of such an amazing event to raise awareness and advocacy for mental health and addiction. Avenues Recovery is so honored to be a part of this event, partnering up with mental health associations for Baton Rouge. Just want to give a big thank you to the staff over there, Melanie, Melissa, Laura, Amanda, and many others who make these events possible. My name is Shannon Coutois, and I do the outreach for Avenues Recovery. Avenues Recovery is a treatment center that treats for any and all addiction and substance use disorders. Avenues nationwide has a total of 10 facilities, and actually in New Orleans, in the New Orleans metro area, we have 2 facilities that are nestled into the community. We're able to treat up to 92 patients between those 2 facilities, which is amazing. We offer medical assisted treated detox, so that's your high level of acute detox. And we also can treat up to people up to 90 days of inpatient care. We know from a clinical standpoint that giving people the longest time in recovery or in treatment gives them the greatest chance for success for longer term sobriety. That being said, our highly and dedicated staff meet people where they are. So when people come into treatment, we take them from head to toe, starting with the awesome medical director who you'll hear from later, Dr. Susan Julius. We'll give them a complete workup and make them as mentally, medically stable as possible so they're able to engage inside of the treatment community and get the most they can out of it. Our clinical staff are a highly dedicated and passionate staff. Not only are they highly trained, but a lot of them are in recovery themselves, going from the techs to the nurses to the to the clinicians. We're able to really make them feel comfortable and to be able to understand where we're coming from, having longer term sobriety and inspiring hope. We teach them cognitive behavioral therapies, how to live life on life's terms once they leave treatment. Because we really know that long-term sobriety not only starts at the level of inpatient, but it continues on once they leave our care. And so Avenues Recovery is dedicated to being able to help them navigate the challenging roads of recovery and early sobriety. We take a great pride in being able to meet people on the front line and to be able to treat them with dignity, respect, and deliver the highest level of care that we possibly can. So again, I'm excited to be able to be here and to be a part of such a great event and to know, and I'm excited to hear from our expert panelists, 2 of them which are my team members over at Avenues Recovery. You have Leah Rosa, who's the clinical director, and you have Dr. Susan Julius, who is the medical director. So again, thank you so much.
Hello, my name is Charlene Gradney, and I'm a program manager with the Louisiana Department of Health, Office of Behavioral Health. On behalf of the Office of Behavioral Health, I would like to thank and welcome each of you for joining us for today's event. We are excited to partner with MHA for community events like these The Office of Behavioral Health has a long history of partnering with MHA as we share the same passion to educate individuals, families, and communities on behavioral health issues and how to access resources and programs in your local communities. The Louisiana Department of Health is committed to the advancement and promotion of positive health to include positive behavioral health practices. LDH navigates with the purpose of assisting the citizens of Louisiana every day, and especially as we navigate this unprecedented health event. Dealing with disasters can cause stress and strong emotions, particularly during the COVID-19 pandemic. It is natural to feel anxiety, grief, and worry. Coping with these feelings and getting help when you need it will help you, your family, and your community. The Office of Behavioral Health and its partners have been very committed to the COVID-19 response efforts, as the global health impact of COVID-19 affects not only physical health, but social, emotional, and behavioral health. While the physical health impacts of COVID-19 are more widely known, the emotional and mental toll of this pandemic is also far-reaching. Mental health is as important to our overall health as physical health. If these stressors are not addressed and handled properly, the impact may lead to unhealthy choices, potentially including substance use and increases in negative coping and emotionally reactive behaviors. As the people of Louisiana, we continue to work together to live with the new reality of COVID-19. Unfortunately, we are no strangers to crises and disasters, as Louisiana now faces recovery from the devastation caused by Hurricane Laura. It is the commitment of the Office of Behavioral Health to partner with community programs such as MHA to provide support and resources, as well as hope and encouragement. While we may be practicing physical distancing at this time, we have never been more connected to the people we are called to serve. The Office of Behavioral Health thanks MHA for hosting this event and their commitment to serving the people of Louisiana. We would also like to thank the local partners for joining as presenters and co-hosting this event. We thank you for joining us today for this very important event.
Hi, everyone. I'm Dr. Susan Julius. I'm the Regional Medical Director with Avenues Recovery. Welcome to Behavioral Health 911. It's an honor to be here today. Thank you for having me. Today, we're going to talk a little bit about addiction, mental health, and the changing climate and how the world is affecting this dual diagnosis problem. So let's get started. First thing I'd like to share is that I'm in recovery. I'm a family practice doctor and an addiction doctor specialist. I'm also a physical therapist and trained in urine drug testing analysis. This is the place where we work. This is Avenues Recovery Center. We have a 92-bed location. This is Townsend. We're on the 5th floor of New Orleans East Hospital. We have 36 beds, detox, residential, and partial hospitalization. This is the central nursing station there. And this is our Avenues Metairie location. This is 56 beds, and we do ambulatory detox, residential, and partial hospitalization treatment here. The phone numbers are at the bottom, and I'm going to be showing you this again at the end of the slideshow. So the topics today, addiction, co-occurring mental health disease, our biggest challenges in the climate of COVID, and what our solutions are, my passion, and raising awareness, how we can make things better. So they always told me to start off with a little bit of a joke, and this is that crazy look you get when you see your old dealer is the one chairing the meeting. All right, so addiction, how many people have it? It's at least 10 to 20% of the world's population. So what I want you to remember is, you go into the grocery store, every 10 people, 2 out of those 10 will have some kind of either a substance use or a process addiction. They could be drinking, drugging, watching too much Netflix, overeating, but 20%, up to 20% of the population is affected. The sad part is only 10% actually get help. So that leaves half the people in the world with addiction not getting the treatment they need. Of those with substance use disorder, approximately 40% have a mental health condition with it. So we call this dual diagnosis. And only 50% of those people wind up getting treatment for either disorder in their lifetime, which is really crazy today because we have tons of places where they can go get help. Addiction, I think one of the reasons people don't get help is it's been seen as a moral failure. As you can see this picture here, when you picture the word addict, people think of a junkie lying in the street with a needle in the arm. It doesn't have to be that way. You know, we don't like to use the words, he's clean now, the drug test was dirty. It all connotates a sense of badness or wrongness. And I think this is one of the reasons people don't get help. There's still a lot of stigma in the world with mental health illness and addiction. And it makes it tough to treat. The attitude, many people suffer and they don't get the care that they need. The thing that I want you to remember is addiction is a disease. It's not about free will. It's not about just say no, courage, willpower, or determination. If it was, our treatment centers would be empty. Addiction, I want you to remember, is one disease. We don't discern between this person's an alcoholic, this person's an addict. We also try not to use those words because it connotates an image of we don't call the diabetic, this guy's a diabetic. We try to say now today, the person has diabetes or the person is in recovery from the illness of addiction. And we don't use the words drug of choice. We try to use them thinking, I want you to think of it as a most effective reward. Alcohol may be a most effective reward for one person. Another person may like methamphetamine. So they're all rewards. And the rewards act the very same in the brain. And I'm going to teach you that today. So this is the ASAM, or the American Society of Addiction Medicine's definition of addiction. It is a primary chronic disease of the brain. Reward, motivation, memory, and related circuitry. The dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. This is reflected in an individual pathologically pursuing reward and or relief by substance use and other behaviors. It is characterized by an inability to consistently abstain, impairment in behavioral control and craving, a diminished recognition of significant problems with one's behaviors and interpersonal relationships, and a dysfunctional emotional response. Like other chronic diseases, addiction often involves cycles of relapse and remission. Without treatment or engagement and recovery activities, addiction is progressive and can result in disability or premature death. Addiction has two main types, type 1 and type 2. The most important, the biggest type is type 2. 80% of people that have addiction have type 2 addiction. So most of the patients that you see or the clients that you're going to see, and you're going to hear this over and over and over again. You'll hear it in AA meetings, NA meetings. I just never felt part of. I never felt normal. I didn't feel right until I had that first shot of heroin or that first snort of methamphetamine. People that have low dopamine tone are irritable. They're frustrated. Nothing makes them happy. They can't connect to each other, other people. They procrastinate. They can't focus, and they have poor memory. So 80% of your clients, you're going to see this. Every once in a while, you'll have a patient or a client that has high dopamine tone. They have too much of that chemical, that neurotransmitter in the brain. These people are born with tics. They may have twitches in their face. They may have, you'll listen back and you'll hear them tell you they stuttered when they were a child. People that have severe phobias, agoraphobia, claustrophobia. People that have obsessive compulsive disorder, repetitive touching things, numbers always having to be on a certain number 3, counting, washing. These people have too much dopamine. And when they use alcohol or a drug, the surge of dopamine goes out, but when it crashes, it calms them down. So you'll hear them frequently tell you, when I have a drink, it calms me down. It calms me down. But you have to be careful and remember that people drink with type 2 addiction as well. These people, you're going to hear this is the pattern you're going to be watching for. So let's try to put it together. There's 5 main chemicals in the brain that we're going to talk about today. There's probably more than that, but the 5 we're going to focus on are dopamine. We went over, that's the one that gives us the reward and pleasure. Serotonin is the feel-good chemical, 5-HT. It's released in the brain up at the cortex level. It's the one where all the people take their SSRIs, their selective serotonin reuptake inhibitors. All those medicines, Prozac, Paxil, Celexa, Effexor, they let serotonin sit here longer so we don't feel nervous, so we don't feel anxious, okay? The third chemical is norepinephrine, or adrenaline. Adrenaline makes us get out of bed, run away from a bee that's getting ready to fight us or bite us. GABA is the fourth chemical. It's an inhibitory chemical. It stops excitatory actions in the brain. It calms the brain down. GABA is what's created when people drink. It's in the same class when people drink and do benzodiazepines and take phenobarbital. This is where all those drugs work. And when you stop those drugs, GABA is taken away and the brain is excitatory. And that's why people that have withdrawal from those drugs can have seizures. So GABA is an inhibitory chemical. Whereas glutamate, the fifth chemical, comes down here and it's excitatory. It makes the brain synapses happen, and I'm going to go over that in a second. But glutamate comes down from the amygdala and it creates the spike and crash of dopamine and brings back the memories of a certain song was on, and when you dated that girl, you guys had a great time and you got drunk that night, and all of a sudden you hear the song and before you know it, you're going to buy a beer and you didn't even have any intention of buying a beer. That's what glutamate does. And that's why people can relapse 30 and 40 years later after they haven't even had a drink for all that time. The nature of brain irregularities created by addiction in combination with environmental factors and genetic predispositions may cause cravings that can lead people to relapse months or years later. That's what I was telling you about with the amygdala. Repeated exposures to large amounts of addictive drugs changes the brain so that it functions normally when the drugs are present and abnormally when they are absent. So you ask yourself, how do people get addiction? Can some people just get it by taking a substance too much over and over again? Yes, they can, but only 10 to 15% of the population will get addiction just by giving them a substance over and over again. Like you go to the doctor's office and you get Klonopin for anxiety. Only 10 to 15% would develop that way. The bulk of the people that have addiction, it's due to genetics. 60% is genetically passed on, but the environment is important too. If I brought the person up in an environment where there was no access to drugs, they wouldn't have as much opportunity. So remember, genetics and environment are important together. And the last thing that usually comes that comes along is stress. When people are stressed, the chemical balance of their brain is altered. Dopamine drops. So if I come into a job and my boss yells at me every day and tells me I'm no good, you're not doing this right, or your wife, you come home from work and your wife screams at you that you didn't bring enough money home, or you're the father and parent yelling at the kid, your grades aren't good enough, or there's no food to eat that night, there's no shelter for the house. You're brought up in a home where there's molestation, you witnessed a rape that day, or another hurricane is coming, or COVID is out there. Any kind of stress, even good stress, getting a new job, it deregulates the chemicals in the brain, drops dopamine. When dopamine drops in people with the disease of addiction that are genetically prone to it, they reach out and do a drug, do a behavior. So remember this, stress, the genetics, and access. You have to access. And today, drugs are everywhere. So why aren't my people getting help? Well, a lot of them are in denial. And then the stigma, they're worried about losing their jobs or what other people are going to think of them. And a lot of people still have lack of resources. They don't come in, they're from the outlying areas in the state. Insurance can be a barrier, and the concerns about cost. This was actually one of my patients. A family member sent me a text with a picture of what they actually went through that night. You could see the craziness, the broken plate, the wine, the bottle, and the pills. The 5 things that we teach our patients, and we move them cognitively through this. And what happens is we'll flip back and forth. Someday person will totally get it and know that they can never touch another drink. And then when they go outside on an event, we take them for an outing, and they come back and they realize they went to the park and they thought about how they had a picnic there and drank, and it hits them, and they can't believe they can never pick up another cocktail or another beer. The first things we try to teach them is, I have a problem. The problem isn't that their kids are taken away from them. The problem isn't that their husband wants a divorce or that they lost their job. Sure, those are problems. Those are just symptoms of the disease. The problem is that there's a disease in the brain. And the disease is not going anywhere. It's chronic. It's progressive and terminal. At age 62, I tell my patients, I'm sicker than you are because I'm older than you are. If I picked up drinking or drugging today, I would be right back at where I left off years ago, because every decade we lose 7% dopamine tone. And when dopamine goes down, that's what we want to do. We want to drug. The 4th thing that we try to impress upon them is that they cannot fix themselves. That's why we reach outside of ourselves for help. They come to treatment centers. They go to AA. They go to meetings. They go to Zoom meetings. If they could fix themselves, we wouldn't have any work to do. And this is the part that they always seem to falter on, and this is why the treatment centers are open every day, is the last part, which says, I cannot take a vacation from recovery. And this is what happens. We get complacent. We don't want to go to AA anymore. We don't want to keep working out or exercising. And I tell ourselves, we had a great 3 years sober. I can have a cocktail again. I had shoulder surgery. I deserve to take that pain pill. My shoulder hurts. And that's where relapse happens. 70% of people relapse with this disease, 70%. And I keep trying to tell my patients, you don't have to be part of that 70%. So the hard part is trying to figure out, is it depression? Is it anxiety? Are they bipolar? Is this meth-induced psychosis that I'm seeing? Is this just untreated addiction? Is there post-traumatic stress disorder? And so when patients first hit our door and they're not feeling well, we have to try to tease through all these different co-occurring diagnoses. We try to peel the onion. We try to get the person stable, get them able to sleep at night, able to eat, get them back doing their activities of daily living, dressing, bathing. And as we peel the onion and get to meet the patient and know them better, these are the things that we're seeing. Many people come in with depression, and it's a co-occurring disease with the diagnosis of addiction. There's anxiety disorders, bipolar disorder, or manic depressive. Many of my patients have PTSD, or post-traumatic stress disorder. And we see antisocial personality disorder. It comes with addiction. Many people that drink wind up getting DUIs. Drug use winds up people, stealing, hustling, selling drugs. It's all part of the disease process. And I try to tell my patients they're not bad people. We just do the wrong things to get what we need. And remember, when people are low in dopamine tone, they don't care. They'll do anything they can to get what they need. And lastly, schizophrenia is seen in patients that come. And this is not an all-inclusive list, but these are the top ones we see a lot of. So what's going on with COVID and the changing times? COVID has brought a terrible sense of fear over the whole world. We don't know what to expect. And there's so many personal beliefs that are going on. Science is trying to keep up with research as fast as possible. But if we take it down to just the community level, people are sitting at home. They don't need as many people at work. They're shutting things down. So people have lost jobs. They feel insecure. And remember, when this happens, dopamine drops. Housing. People are losing their homes. Families, they're all crammed together, and then they get worried that they're too close to each other. They're afraid of becoming ill. We can't leave. We can't cohabitate. We're not supposed to go out and be with others. AA meetings have stopped, so friends have lost contact. We've seen amazing things happen with the unemployment and the stimulus money, but we've also seen it as a double-edged sword. A lot of my patients, unfortunately, are using this money. They've never had money like this before, $600, $750 a week. So they're using it to buy drugs, which is unfortunate. But we're trying to teach them to save that money and keep it for a bed at an Oxford house, for food, for clothing, for trying to save up rent so they can get into an apartment. The surge in fentanyl, which is a synthetic opioid, has been unbelievable in the last few years. And I'm going to show you a couple slides. This product is coming in parts, and it's coming from different parts of the world. They bring it in, they put the parts together, and they ship it across the borders. It's coming in through the ports. It's coming in through the borders. The other problem that's unbelievable right now is methamphetamine. If you look back in history, whenever there was a huge opiate swing, right after it, there's a big stimulant swing. And then again will come an opiate swing. An example is in the 70s, when the people came home from Vietnam, there was a huge opiate swing. In the 80s came cocaine. 90s, the pills, the pill mills, doctors, heroin, because people couldn't keep up paying for OxyContin because it was so expensive. So then comes the opiate swing with fentanyl. And now we're swinging again with more stimulant again, and it's the methamphetamine. What's even crazier is my patients don't even know what they're taking anymore. They're buying pill presses. If you Google pill press and you pull up the images, it's unbelievable. And you see these on drug busts in the news. They're taking all these different drugs, packaging them all together, pressing them, and making them look just like Xanax, making it look just like oxycodone. I had a couple came in, they swore to me they were taking OxyContin. They were paying $30 a pill. It was straight fentanyl. There was no oxycodone in their urine, none at all. People are dying like flies from this drug because it's 100 times stronger than morphine. 100 times stronger than morphine. I want you to remember that. The fentanyl is coming out with blue colors, green colors. It's unbelievable. So these changing times drops our dopamine. We socially isolate. And when dopamine drops, the receptor density drops. And this leads to relapse. I've had patients tell me the AA meeting, the NA meetings, they're just not the same. I don't feel like I'm involved as well. They're also not getting out and doing service work, so they don't feel useful. Doing service helps upregulate the receptors for the dopamine. And so the patients and the clients actually feel better. When people drug at home or drink at home or use at home, their home is associated with drug use. So they're constantly getting cued from the amygdala that I used to sit over my couch and do drugs right over there. So now they're stuck at home in the same place. It reminds them of using. We ask ourselves, when people are trying to go to their doctors, the time of telemedicine has helped intensive outpatient programs, but I think there's some shortcomings. For 3 hours when you're sitting here trying to listen to a Zoom meeting, are you really listening that whole time? Are the kids running in? Is the husband coming in? Are you trying to do another activity? So I wonder how effective Zoom meetings really are. The other problem is collecting urine drug tests. We like to make sure that urine is warm from the person that we get it from and their urine, and that they didn't try to alter it or adulterate it anyway. So now in today's times when people can drop urines off at the IOP programs, we worry that is it truly their urine? Hopefully they're drug testing on site. And people are stuck at home. They're not getting their workouts like they used to. At Avenues, the solutions that we're trying to help the world and help our patients and help the people of Louisiana is that we want to tell them that treatment is inclusive. We don't keep people out. We want it to be all included. And that's why we try to accept Medicaid and private health insurance, and we treat people equally here. Remember to tell your clients that detox days are separate from residential. People get it in their head, the magical number 28 days, I think from Sandra Bullock movie, or 30 days. I'm going to be there 30 days in the program. You want to come into treatment with the idea of, I'm here for you, I'm yours, help me, and not worry about the day's stay. Just enjoy and learn and allow your brain to heal. That's what you need. You need midbrain stability to be able to have cognitive change, to have a spiritual awakening. That's what needs to happen. We tried to recommend a 90-day program to our patients. A Medicaid coverage does differ, but that's what we try to encourage. And if they can't stay that whole time, we help them get placements at sober living facilities. We try to treat the dual diagnosis. I started a hepatitis C treatment program here at Avenues. And in the last year or two, we've treated probably close to 200 to 300 people. I think it's phenomenal. The state of Louisiana is on a program of allowing 84 doses of generic Epclusa to all the people with hep C that that can take that medication. And the goal is that we eradicate hepatitis C by 2025. We involve the significant others, the family and the friends, and we help them with things like FMLA, family medical leave, short-term disability, long-term disability forms, getting their checks while they're here if they're due money. We help people with court. We write letters for court because they're worried about missing court dates. We get involved with the Department of Children and Family Services. We'll write letters to help mothers and fathers win their children back or keep them. If you have an injury or an illness, we keep that very noticeable on the medical plan, and we take you to your medical appointment. If we have the ability to drive you there, we will actually drive the patient to their doctor's office appointment to keep them up with medical care. I try to do excellent family medical care while they're here. And so if it's something that I don't feel comfortable with, we'll get the patient to where they need to go. And one of the goals that we try to impress upon our patient is it's okay to need medicine. Many patients come in, I don't want to be dependent on anything. And I say to them, well, that's a good idea, but let's treat the disease. Let's get your brain stable first. And we're trying to go toward longer acting medications. Subutex in a long acting form is called Sublocade. And it's a small injection that goes under the skin, under the belly. And what it's doing is it's reducing the amount of Suboxone films that are out there on the streets. I'm worried that they're going to stop making this a Schedule III drug. If we keep diverting it and selling it and trading it, the government could make it Schedule II, and that makes it very difficult. The person has to be seen in person, so there would not be any telemedicine prescribing. There wouldn't be any calling in or faxing prescriptions. So the less drug diversion, the better we are at keeping the medicine at the level that it needs to be at, and improved adherence. So they go for a shot once a month. That way they don't have to think about taking their films 2 or 3 times a day. Oh, you know what, I'm fine today. I don't need this today. And then before you know it, somebody else can pick it up or they can sell it or divert it. And longer acting medications bring better steady state levels in the body and in the brain. And it helps with cravings. Again, this is our Avenues location. It was wonderful to be here with you today. I wish you good health and recovery. And this is our Townsend location. Thank you very much.
Hi, thank you so much for joining us today. My name is Leah Rosa. I'm currently the facility director at Avenues Recovery Center in Metairie. I am a licensed professional counselor, a nationally certified counselor, and a master addiction counselor. I have also worked in the mental health field for upwards of 20 years and have done the Love First clinical intervention training. I've spent the bulk of my career working in addictions and am working obviously in an inpatient treatment facility at this point. I thought today that we could share with you a little bit about recovery in 2020 and what that looks like, what we're sharing. We have challenges that we're facing. We have changes, and we are looking toward and figuring out our momentum forward. I would definitely say, and I think everybody would agree with me, that 2020 has been quite a year, and it's not over yet. There's no way that we could begin this discussion without acknowledging the unprecedented challenges that this year has brought to mental health and to addiction in particular. I know that we have seen an increase in overdose rates. And I say that initially not to scare people, but truly to inform them of the dangers of this escalating epidemic that we're experiencing. We are seeing that locally. We have seen it here in Jefferson Parish. We have seen it throughout Louisiana, because we do have people coming from throughout the state. We know that Baton Rouge has dealt with this. Jefferson, Orleans, St. Tammany are all reporting to different degrees a significant uptick in the amount of time that they're having to respond to these events. And we know that these are particularly devastating. So we've seen that without a doubt. We have seen an increase in the number of first-time patients in treatment. This is a little bit unusual, and I think we're going to talk a little bit later in the presentation about why we're seeing this. And we have seen an increase in the return of patients. And I think that it's really important when you hear that not to go to a place where you are particularly judging that, because we have seen people that manage to get into recovery for a period of time, but this year of 2020 has caused so much stress. It has caused different types of trauma for people, and for whatever reason, they have had to return to treatment. And I will tell you that we as addiction professionals consider ourselves emergency responders in the current situation. When the COVID shutdown initially occurred, there were many places that provide services for people with mental health and addiction that were unable to keep their doors open, that went to completely online or telehealth services. And there were some places that simply shut their doors for a period of time. We, without a doubt, know how important our presence in the community is and how important responding to this crisis is. So we have seen that just in the first 10 months of this year, and we expect to continue to see it as the climate changes around this year. With regard to stress, and particularly in the year of 2020, one of the things that we know is that stress in the environment can worsen biological vulnerabilities. And really what that means is that it makes the symptomology that people are experiencing worse. We know that significant stress can cause relapse. And so I'm going to go over a list of serious stressful events that people experience. And so we know that if someone experiences any one of these things, that their likelihood of experiencing a significant or new mental health issue increases. And then if you look at the list, you will see that many people have experienced many of these things in the last 10 months. So I would say, losing a loved one, starting or ending a relationship, job loss, career changes, moving, financial struggles, conflict with those you're close to, and I did put parenting in there. And I think that that is just general parenting, but certainly parenting if you are struggling with a mental health issue. And then I'm just going to say homeschool has caused really and truly a lot of significant stress for people. They love their children. They want to do the best they can for them, but there's a lot of stress involved in that. And I think if you look at, stress, and then what we also refer to as like collective trauma. So what's happening is that we have and we see trauma blocking behaviors that occur. So let's talk a little bit about what is trauma blocking. So when someone has experienced something they experience as traumatic, or they are vulnerable to that because they previously experienced this trauma, right? And they don't want to be in a position to re-experience it. So people either take a trauma and synthesize it and work through it, or they stuff it down. And so we look at what is, trauma blocking. So to avoid pushing down, I always say it's like the beach ball. If you were ever a kid and you were in a pool and you had a beach ball and you played the game where you pushed the beach ball underwater, the game only lasted so long because eventually it would pop back up, right? And usually it hit you in the face, to be quite honest. And so we see that, right? And so these are the things that we see just the general public engaging in, and you'll see that how some of these things can lead people back to needing significant help for mental health and addiction issues. What does a trauma blocking behavior look like? One is excessive use of social media and compulsive or mindless scrolling. We know that is something people have in their hands, they have consistently available to them. Compulsive exercising to reach a goal that they're never satisfied with. This is different than taking care of yourself. This is when it becomes compulsive and also you never reach an end goal. Excessive and mindless eating, even when they're not hungry. Compulsive online shopping for things that aren't needed, especially in this current social situation with lockdowns and, internet shopping is up, I think 150%. But we also see people binge drinking and using, particularly when off from work. And we see compulsive overworking, having poor boundaries at work, and being available 24/7. So you would see how all of those things are things that people can use if they're experiencing trauma, not to deal with it, or if they have experienced trauma in the past. Some of those things can get out of control. And one of the things that we know for sure is that binge drinking and using, particularly when people are vulnerable and are experiencing a lot of stress, lead them to a situation where they need to seek help because it becomes a compulsive behavior. I wanted to talk a little bit about the stress vulnerability model of co-occurring disorders. So we do treat co-occurring disorders, and that is when you have a psychiatric and an addictive disorder. They very often occur together. They influence each other, and they have to be managed and treated together for treatment to be successful. What we'll often see is people who have previously gotten treatment for one or the other, but not both at the same time. We provide that treatment at our center, and we know that that leads to a better outcome. There is a vulnerability that is determined for some folks just by their genetic makeup and by their early life experiences. And then, so when you have that vulnerability already there, the stress vulnerability model emphasizes that people with this biological vulnerability to addiction and co-occurring mental health issues have to mitigate it, right? If they're going to do well, they need to usually take medication, and they have to do it appropriately, or they can also use medication in a way that does not work well, or drugs in a way that does not work well. And then they also use three things. They use coping skills, they have to have social support, and they have to have meaningful activities. And I think that anyone who is evaluating anything that's happening understands in our lives that right now having coping skills available to us they may be wearing thin. Things that worked for people in the past are not currently working as a coping skill. Social support has been obviously particularly difficult in 2020. In the recovery community, there went to a lot of Zoom or online 12-step meetings. Many people, even in good recovery, struggled with that or disengaged. And I think that there is just something about seeing people in person that tends to bolster people. So social support, and even just having supportive friends and family. Sometimes when our friends and family are stressed out, they might not be as available as they once were for people. And then meaningful activities. There's been a lot of meaningful activities that were just discontinued to keep everybody safe, but it still leaves people vulnerable. So, we have this, or we know what makes a difference for people that already have this vulnerability. And I think when you look at trauma and addiction, it's really important to understand that childhood or early life trauma is specifically linked to an elevated vulnerability to addiction. And I think a lot of people that we treat come in and maybe don't understand that link. So it's important for them to understand and really getting to the heart of what they need to work on. We have current stressors, lack of social and coping skills and social support and meaningful activities are leaving people who may have been treading water unable to cope. So I say all of this to really encapsulate that we have people that were doing okay before this, and they find themselves in a position where they can't tread water anymore. And then we had people that weren't doing well that are doing even worse. And so those are some of the particular challenges that our patients are seeing and that we're seeing in the field. I think that it's really important to look at, how do we address co-occurring disorders in treatment, right? Because so if you have depression or anxiety or any other mental health and a substance use disorder, these are the things that is really important. So if you have someone that you care about, they need treatment, you would want to make sure if they have a co-occurring disorder, and most people do, that all of these things are included. I would say accurate and thorough assessment of each individual patient is going to be tremendously important. They need to have medical detox and stabilization available to them. They need medication management and medical oversight. Tremendously important for stabilization. We do individual counseling. We'll do group counseling, which have different benefits, both of them. And then we do 12-step education and involvement in the program to treat both disorders. We have a really important aspect would be developing effective aftercare recommendations. It's a tremendously important thing to know that a treatment center does, because we talk about stabilizing people and then they have to leave and do the work on their own. We're going to talk a little bit more about that. To provide case management, we provide peer support, and then we have the element of time, which is tremendously important when someone has a co-occurring disorder. So I think that people would ask me, why is time a factor in improving outcomes? Because all of the things on the previous slide that were listed do improve outcomes when someone has a co-occurring disorder and needs treatment. I like to talk about this. So we talk about this, a beautiful day. We tell patients all the time here, what a beautiful day. Like, we do drug screens, and we'll often say it is to monitor your progress. We would certainly need to know if something was going on with someone, but also, check in with your counselor. What an amazing day when you finally get the screen that says all of the drugs are out of your system. And all of our patients will, shake their head. They agree. It is a beautiful day to know that you are clean. And that takes time. And I think that often when people, dependent upon what they were using, want to rush through that process, that becomes very difficult. I would say that people don't like to hear this, but that there is nothing magic that happens at 28 days. 28 days originally came from the AA tradition of, helping people, getting them stabilized, going to a meeting every day. And what we know about habits and what we know about really changing and shaping behavior is that it can take longer than that. It takes up to 90 days to make a new habit. This is not any different. And there are some clinical implications for why time matters as well. So, in the first 28 days, I will tell you that we very often see that a patient is stabilized generally, and then they're cleared. So we may be continuing to work on medication and getting that improved outcome. Some medications for mental health issues, can take 3 to 4 weeks just to get that effective dose on board and really doing what it needs to do to then know, do we need to spend time increasing that dose, or is it working well? So that takes time. But I'll share with you what we often see. So we believe in long-term treatment. We know that there are better outcomes. And when we see that a patient has stabilized and has cleared, what will often happen is they are then sitting in a new place in their life, and they have now in their lap looking at how did I get here? Because it is tremendously important for them to begin to feel their feelings, is what we'll often talk to them about. New emotions that have been dulled often for a very long time, looking at uncomfortable situations, looking at their particular coping style, coping mechanisms that weren't working really well for them. And it takes all of that occurs over time in treatment. And the beauty of it is that when someone is able to stay in long-term treatment, they are able to address those things with a clinical staff that has been with them the whole time while they've stabilized. And then we get to really start doing the work, not the work of stabilization, but the work of moving them from one place to another, right? Moving them from abstinence into true recovery. You know, at Avenues, we believe in long-term care. I love working here because I love our philosophy. And I will tell you that, you know, I love it. Avenues recognizes that addiction is a chronic, progressive, and relapsing disease, regardless of what caused its onset. I think that it is really important for people to hear that the reason why someone starts using and the reason why they can't stop are two completely different things. And family members who've had difficulty really struggle with that. And I think one thing that family members should know is that the progression is not inevitable. It can be prevented with timely intervention and extended care. And we use, of course, evidence-based therapeutic modalities, and we use medically assisted treatment. And the combination of those two things allow for a lot of success. And then when we talk a little bit about our mission, you know, we're committed to maintaining the highest industry standards by tailoring treatment intervention to meet the complex needs of each client, because anyone who works in this field knows for sure that every client is an individual and has different needs. We definitely all work as a team, and working together, we swiftly respond to threats to recovery, and we never give up on a client. We leverage challenges as clinical opportunities to maximize each client's recovery potential and facilitate deep-rooted change in beliefs and behaviors. And I love that, you know, that is our philosophy. We never give up on a client, and the challenges that they're going to face, which are not always just abstinence, right? When we're starting to look at people looking into their past, people looking at how they got there, also developing where they're going to go moving forward. And the challenges they experience when they face those things, we look at as a clinical opportunity to help them get better. I think that it's important to know that long-term care gets people into recovery. Even if someone goes for 28 days, and this is our philosophy for all of our patients, they go for 28 days, we're always going to recommend an extensive aftercare plan, because treatment can continue outside of an inpatient facility. But it's important for people to understand that recovery is not simple abstinence. I love this quote by Deborah J. She says it's about healing the brain, remembering how to feel, learning how to make good decisions, becoming the kind of person who can engage in healthy relationships, cultivating the willingness to accept help from others, and daring to be honest and opening up to doing. And that is a quote by the great Deborah J. She wrote 2 books. One is called Love First, A Family's Guide to Intervention, and the other is It Takes a Family, A Cooperative Approach to Lasting Sobriety. This is the Love First book. If you are interested and looking for a recommendation, if you have somebody that you love and you think that they may need an intervention, this would be the book to get. This gives families a way to do this even without a professional, but of course you can look them up online, and there are Love First clinical interventionists available. And I love this because getting family members into recovery can be a very difficult and very scary time for families. And they feel like it's going to be mean, and it's, you know, it's going to hurt the person. And truly, this whole methodology comes from accessing that place of, I really, you know, we really love our person who's struggling, and we want you to get help. The other book is It Takes a Family, and that is about a cooperative approach to lasting sobriety. That is the book that I would recommend for family members if you've had someone that's gone through treatment. It talks about what if family members do themselves. They'll often feel like, maybe, what do I need to do? Family members are affected by someone having a substance use disorder. And so there's a lot of good information in this book. So I always recommend those too. But I don't want to lose sight, of the reality that abstinence isn't recovery. And we are really working in that when we have that ability to have someone in from days like 31 to 90, we truly are working on all of those deeper things. For momentum forward in our industry, for individuals, I think that it is really important for us as a community to start embracing this idea of long-term treatment. And for individuals, we need to move them from an active addiction to abstinence. And there's two bridges there, and then we need to move them from abstinence to recovery. For treatment professionals, in going forward, we are continuing to provide services through COVID, which is a very important thing to do. We need to be able to link patients to thorough and very specific aftercare plans. And that is how we are going to have to address this going forward. And we have to be able to ensure that the places that we're referring people to are solid enough that they are going to continue to provide services. Because you can imagine in the cycle, if there is somewhere that does not continue to offer services or the services change, it can destabilize a patient pretty quickly. I think families often wonder what they can do when they have a loved one. They can see it happening in front of their eyes. This person, maybe had a problem, but it seems like it's really getting worse. And I think that just really acknowledging that there's an issue or an escalating issue, which becomes just very frightening, and sometimes families tend to shut down. But just to acknowledge it is the first step. Encouraging loved ones to get help. Again, I go back to considering if you feel like you can't do it, using an interventionist, but getting the person that you love into treatment. And the day that they say they're willing to go in, getting them in that very day. I would encourage families to evaluate behaviors, don't enable the addiction. In Love First, there's some wonderful chapters that you could read about that. Enabling is something that family members do always out of care for their loved one. And I always invite family members to really consider doubling down. And they'll tell someone, they'll say, I want you to go to treatment. We think that there's a big problem. You have to go. And the person will say no. And when I say double down, I often, will say, this is the time when every day when your person is struggling, you call them and you say, I love you. I want you to get treatment. I love you. I want you to get treatment. I love you. I want you to get treatment. Because it always comes from that same place, not of giving up and walking away, not liking the answer. Sometimes it just takes the one day that they're willing to say yes, maybe based on some experience that they had. And this will get them into treatment and start this healing process for them and for families. What can communities and employers do? I think that employers don't understand that they have a huge influence on outcomes. And what I mean by that is employers have the ability to talk to their employees. When people come into treatment, they will often say, I can only stay for 2 weeks, 4 weeks. My work doesn't know that I'm here, or my work expects me back. When we get employers on board that have said to their employee, we want you to get better, your health is important to us, go get treatment. When you are done with treatment and you have successfully completed is really the key. You can come back and you can come back to work. And, however long that takes is how long it takes. You have a valued employee. They have shown that it makes a tremendous improvement in their outcome. And it works for the employer too, because you don't lose an employee. You as an employer are at less risk for having an employee that struggles with a substance use or mental health disorder. And we know that it even improves quality of work for employees. People in recovery, in good recovery, make very, very good employees. And then for community members and organizations, I would say that they have a tremendous opportunity to work to help to remove the stigma that still surrounds addiction. I think that it is everywhere. I think that it's really important to watch our language. It's important to use person-first language, a person with addiction, rather than call people just calling them an addict. That we need to evaluate the stigma that people have, because they really don't understand or embrace that idea that says why they started using and why they can't stop are truly two different things. So I would encourage everyone to really look at that. And so I think that that encompasses and gives you a little picture of what we're experiencing. My hope is that it gives you some insight into what you can do, and that you also feel like you have the opportunity to send someone that you care about to treatment. You know what to look for. And we, of course, at Avenues have 2 locations. We have a location in Metairie, and we have a location in New Orleans East. That's Townsend Recovery Center. So thank you so much for joining me today, and I hope that this was helpful, and I hope that everybody has a wonderful rest of their day. Thank you.
Go ahead, Dr. Avery.
Yeah, my name is James Zeri. I'm with the Jefferson Parish Sheriff's Office. So this is a little different. We obviously are not a social service agency. We're not a treatment agency. However, we are that group of men and women who encounter a great deal of substance use disorder individuals. Information from our coroner's office, as you know, Louisiana is one of the few states that where the coroner's office is involved in orders for protective custody. In 2019, we wrote 472 orders for protective custody. So that means in 2019, over 470 times, our officers went to some house, some place to locate an individual who it was felt by the loved ones was suicidal, homicidal, gravely disabled. In 2020, it's going to be over 500. Now, everybody's talked about COVID. That's certainly a factor here. When you look at that, that's 500 times in 2020, our officers have gone out to contact somebody who needs to be taken against their will to a hospital for an evaluation. Probably based on our looking at those records, it looks like 65% of those orders for protective custody are dual diagnosis. And we all understand that dual diagnosis. So 65% of 500 is what, 325, if my math is right. That means almost once a day, we have officers going to a house to contact somebody. What we've learned over the years is a high percentage of these people, I mean, clearly a doctor and the family said they need treatment, but a high percentage of these people who go to hospitals on an OPC are not admitted at that hospital and are sent back home, to the point that sometimes our officers, excuse me, will simply wait in the parking lot because they know the person's not going to be admitted, and then we then drive them home. So what we've started, it's a pilot program, myself and Sergeant Voltolino, we're acting as case managers, probation and parole, if you will, for this population. So we act as true case managers. the first thing we do on these order for protective custodies is that we will be at the emergency room. Now, my official job at the sheriff's office is I'm director of training. Probably the job that takes the greatest amount of time is I run the negotiation unit for the SWAT team. The bulk of barricaded subjects are individuals suffering from chronic mental illness or substance use disorders. So first thing we do is we go to the emergency room, and I am there with the consumer and the physician and educating the physician as to what really did in fact happen. And many times speaking to the physician and encouraging the family to be there also, so we can encourage that consumer to be honest about what's actually going on. And certainly in that whole area of substance usage, that denial is, as we all know, incredibly high. So that's really the first thing we do. And then we continue to stay in contact with the consumer. Whenever possible, we have the treating facility contact us. The VA's been excellent about that. They have the person sign the appropriate papers so that I then have permission to talk directly to the treatment team, be involved in discharge planning, and work on, because you know that first step, they're not admitted. If they are admitted, most hospitals in our parish, in Orleans Parish, aren't going to keep this individual, and they're going to PEC him. And so we're going to get involved in where are they PEC to? Is that going to be a comfortable location for them? And get the family involved in that. If we can get involved with the district attorney's office, if it looks like we maybe could pursue a judicial commitment so we could get longer hospitalization, we'll certainly do that. We will be in contact with the family, the consumer, and the treatment team. And hopefully by doing that, now we probably have a caseload right now of about 12 consumers. We just started this, really we just started it several weeks ago, and we're already on a caseload of 12. Now this is very different for law enforcement to do something like this, but what we have found is a high percentage of these individuals fall through the cracks, sometimes through no fault of their own, absolutely positively no fault of their own. Sometimes, of course, denial, sometimes high levels of paranoia and denial about their substance usage, and they simply don't want to get into treatment. As you all know, somebody with substance use disorder many times does not want to stop because the brain chemistry is telling them you need to not do that. We are huge proponents here at the Sheriff's Office of AA and NA. At times, I've gone to open meetings, open AA meetings. Anything we can do to stay in contact with that consumer, allow the consumer to say that, yes, you know, we are the police, we are the Sheriff's Office, but respect and empathy. A little bit of a stretch maybe, you know, Freud said that successful therapy was a cure through love. So this program that we put together, we want that consumer to see, yes, their initial encounter was with us. Now on the OPCs, we're just talking the OPCs, obviously, maybe the initial encounter was their family with the coroner's office, but the first encounter that consumer has on an OPC is going to be the police. So the more we can do to treat that person with empathy and respect, and then proceed on with this case management protocol, you know, obviously we're trying to do several things here. The goal is the safety of the consumer, safety of the community, the safety of our police officers. We also have incorporated a very extensive 40-hour CIT program. I think 3/4 of our patrol officers have gone through that. And part of that CIT program is that our officers, and Sergeant Voltolino and I run the training part of that program, is we do field trips, and we are very, very open to any of the presenters here would be interested in having our deputies come out for field trips. I think that's all I've got on this. Again, this is Jefferson Parish Sheriff's Office. We don't have a name for this program yet, but it's case management. It's what y'all that are out there being case managers, we're doing case management because we are where the rubber meets the road, we are the first people to contact these consumers. Again, my name is James Airy. I'm with the Jefferson Parish Sheriff's Office. Contact me at 504-234-3449. If there's anything we can do in Jefferson Parish to assist a consumer or family, we're certainly available for that. And we've got tremendous support from our Sheriff, Joe Lapinto, on this. Thank you.
Okay, can everybody hear me?
We can indeed. And
Okay. All right. Hey, everybody. My name's Erin York. I'm the last speaker for today, and I'm going to try to make this quick and go through it because I really want to hear some questions about Vivitrol. Some of our speakers have mentioned Vivitrol and medication-assisted treatment already, so that makes me really happy. I'm a big supporter of medication-assisted treatment. I am a licensed addiction counselor and a licensed professional counselor in Shreveport, Louisiana. I run Forever Wellness and Recovery. We're an outpatient, and I also am the director of a brand new inpatient called Uprising Addiction Center. We just opened about 2 weeks ago, so hopefully you'll hear from me again and we can network about inpatient. So basically what I wanted to talk about is Vivitrol and therapists. A lot of therapists I meet, they say, oh, that's not my job. That's the doctor's job. You know, I don't know anything about meds. It's not my lane. It is absolutely your lane to educate your clients on what is available for them when it comes to treatment, and medication is a part of it. So I'm going to talk to you about what we can say to them and how we can teach them what it is. Some myths about Vivitrol, and I'm going to go through these. Oh, it's like Suboxone. Isn't that a crutch? Why would you swap one addiction for another? Can't you overdose? These are all myths. When we think medication-assisted treatment, we think of methadone and Suboxone and Subutex, but we also forget the other ones like Vivitrol, naltrexone, Camprol, Antabuse. There's tons of medicines that we use to assist us as therapists in treatment. Vivitrol is not addictive. It is not a narcotic. It is not controlled. You can't sell it on the streets. It has no street value, not addictive. Here's some definitions. I'm gonna blow past this, but SAMHSA explains that the use of medicine with treatment is the most successful, especially when treating alcohol use disorder and opiate use disorder. I'm gonna go past that just for a second. Here's something to think about. With that being defined, wouldn't all antidepressants be considered medication-assisted treatment because we're using a medicine to assist with treatment? And that's an analogy I use with people when they can't grasp the concept. Today I want to talk about Vivitrol and MAT, and I want to talk about how you can teach your client in a less scientific way. You know, we as therapists and doctors on this panel today, we're really focused on how the brain works, and we know all the big bad words, but sometimes our clients are on that level. So I'm going to teach you how to teach them to where they understand it. Anybody know the percentage of relapse after one leaves an institution? And when I say institution, I mean a lockdown, like jail, treatment, rehab, residential, something like that. The number is astronomically 93%. It's extremely high. I got this research from Vivitrol. That number actually happens within the first 12 days of being released. So medication-assisted treatment is so important to give in an institution like rehab or jail because it's an extra tool that keeps them from relapsing for a solid 30 days. The injection lasts 30 days. So what is it really? It's an opiate blocker, and it can also lower alcohol consumption. It's administered by a healthcare provider, which can be you, me, a doctor, pharmacy, nurse. once monthly injection. It's used with counseling. It's not addictive, not a narcotic, and it does require a detox. It's an injectable medicine given once a month. It prevents dependence, but you've got to have an opiate detox. This is how I explain it to clients. If I cut your brain in half, you're going to see two parts. The very middle is that limbic system. That's that impulsive drive, not thinking, you just do section. And the cortex is the bigger part. That's where all the decision making, the skills, the counseling, all that comes in. The limbic region is that part that lights up big whenever drug of choice is put in front of you. And you know how clients might say, I just relapsed, I don't even know what happened. That's when the limbic system really takes over. It's that impulsive, I'm going to grab it and drink it or do it. So what Vivitrol does is it attacks the limbic system. It really quiets it down so that impulsive move doesn't happen. And we all know back in the day, addiction used to be an impulsive disorder. And so the limbic system is really in charge of that. So this is how I explain it to clients. And I know this looks funny, but stay with me. So I draw a big circle and I say, this is your brain, and you have buckets. The buckets represent the mu receptor. The mu receptor is responsible for opiate and alcohol, okay? So people say, well, what about all the other things that make me happy? If I take Vivitrol, will I be happy? Yes, Vivitrol only blocks the mu receptor. The mu receptor is only responsible for alcohol and opiates. So then I draw more buckets and I explain to them that the addicted brain has created more mu receptors. That's why the addictive brain craves more than a non-addictive brain. And I explained to them that they have more buckets to fill. These buckets are screaming, fill me with alcohol or opiates, fill me with alcohol or opiates. And that's where cravings come from. So if we put lids on all those buckets, which is Vivitrol, those cravings are going to go down by over 50%. After I draw the buckets, I explain about the lids. If the client uses alcohol, let me minimize this so I can read my slide. If the client uses alcohol or opiates, they would come in and see that they cannot get inside the buckets to work. So if they're on Vivitrol and they try to drink or take an opiate, the opiate or alcohol, they can't get into the bucket. So nothing will work. Opiates are commonly blocked, whereas opiates are completely blocked, whereas alcohol isn't blocked, but there's no dopamine released. My example here is I don't eat Brussels sprouts. If I were to eat them, they would go to my stomach still because I ate them, but my brain isn't like, ooh, eat some more Brussels sprouts. I'm not happy to eat more of them, so I don't eat more of them. So that's how drinking will be affected. Okay. So how do you start the injection? Number one, you're going to do an assessment, drug and alcohol assessment, ASI, biopsychosocial, whatever you want to do. I get consent signed and educate them on the process. And I also do a drug screen. I do an instant drug screen to make sure there's no opiates or alcohol in their system. Surprise, surprise, clients will lie. But also some clients aren't all the way educated on what opiates consist of. Some people will say, oh, well, I take Xanax. Is that an opiate? And I have to explain to them, no, it's not. I then consult with my doctor on staff. So you have to get an order. You have to have a doctor on staff. And if you're an IOP, you usually have to have an addictionologist on staff. Go over with them, hey, I got a client interested. Can we do this? You and your doctor have to call in the oral form of Vivitrol, which is naltrexone. Why do we have to do that? We have to do that to make sure that they don't have any kind of crazy reaction. If I gave them Vivitrol and they had an allergic reaction, they're going to have that allergic reaction for 30 days, which nobody wants to have. So if they have an allergic reaction, we want to know now. So we give them the naltrexone for a couple of days, see how they do. I've never had anybody have a reaction, but it's just to, cover all your basics. After they don't have a reaction, you will then call in the shot. It's really, really simple. I use Fast Pharmacy. It's one sheet of paper. It's basically a demographic. You're going to give client name, date of birth, insurance ID. You'll put their diagnosis on there and everything like that. And then I send a copy of their ID and their insurance to Fast Pharmacy. I get the shot within 3 to 5 days. and then they come back to my office and my nurse gives the injection. I got a question yesterday about insurance with Vivitrol. Louisiana Medicaid covers Vivitrol 100%. Most commercial insurance covers it 100%. Some you'll have a small copay. If you have somebody that does not have insurance, the injection is very, very expensive. It's about $1,200. The good news is the oral form, the naltrexone, is about $40. And so sometimes the people that don't have insurance are really a good candidate for the naltrexone. It works the exact same. The injection is more successful because they don't miss a dose. They don't forget to take it. They don't, avoid taking their pill. Obviously, the injection is a higher success rate, but naltrexone works just the same as long as they're taking it. And if you know an opiate addict, you know that they, spend roughly hundreds of dollars a day or even a week. So $40 a month is not too much. My last couple slides, this is how to get a representative to you. I've learned everything about Vivitrol through my representative. You can get a rep to come to you and they bring you lunch. So you can go to this website and hit request a rep. I know we have one in Shreveport and I know we have one in New Orleans. They travel, they can do Zoom, they can come to you. They bring you all types of materials. They also bring you things for your clients. So I have this little pack that my rep has made me. This is a bracelet, dog tag, and medical ID that I give all my clients that are on Vivitrol. This is so any medical provider, paramedic, EMS, first responder will know that they're on the medicine. And that way they know that if they inject them with any kind of pain med, that it will not work. That's really important that your client has that information. We kind of ran out of time, so I had to be really, really fast. If anybody wants to connect with me, here's my information. Take a screenshot of it. I am at 2 locations. There's my email address and also my phone number. If you want to know more about me, my programs, or Vivitrol, I will be more than happy to help you guys out. It is so much easier than you think it is to get Vivitrol and get your clients on them. I have seen amazing success rate. Vivitrol had a study that their success rate is in the 80% success range, which is amazing. It's been a godsend for a lot of people who struggle with opiate use disorder and alcohol use disorder. So that's me. I'm Erin, and if you have any questions, drop it in the Q&A or give me a call. Okay, Miss Melanie, I am all done.
All right, thank you everyone for sticking with us and listening to these amazing panelists. I am Melanie Henderson. I'm the Advocacy and Education Manager with Mental Health Association. So now we're going to open it up to some questions. I have a few that came through for our panelists, so I will just say who they're directed to and then y'all can hop in. And if you're, like I said, if you're in the audience, please submit any other questions that you think of through the Q&A. So Leah, I have a question for you. What are, or how do you incorporate fun into recovery?
Oh, I think that's a great question. So even in the treatment center, we prioritize that in terms of our weekend activities. And we talk about it's as the same as addiction as a brain disease with regard to any other type of treatment, rewiring that. What we know about your brain is what fires together wires together. And so having fun in recovery is tremendously important. So we do activities, we'll take them off campus, like we do a high ropes challenge course, sometimes we'll go canoeing, it's as simple as we'll have snowballs, we'll have a pizza party. And while all that sounds like, why would that be an important part of treatment? It really is, because knowing, one, that you can have fun in recovery is a huge part of it. And 2, we want to help them rewire their brains and see that that's a possibility. And so, like, I remember last year we had a pumpkin carving activity, and I had people come to us and say, I've never carved a pumpkin before. I haven't gone to a party sober. And so fun in recovery is tremendously important.
Great. And you mentioned coping skills in your presentation. What are some of those that you can suggest?
So in terms of positive coping skills, so we're looking at anything that supports a positive mental or physical state when we talk about that. And so we really look toward things like exercise as really important for coping skills. Engaging with others, having that sense of community is like we talked about, is a huge coping skill that allows people to get through some really tough times. And so that sense of connection, which we know many people in their active addiction lose and then find again in their recovery. So anything that allows you to have like a positive engagement and remain connected is a coping skill. And then, you know, we also look toward, you can work with mental health folks on maybe what particularly you struggle with in the ways that you think and coming up with new strategies for that. And so that is a different coping skill. So that's all internal, not just external. And fun is actually a huge coping skill. So.
All right, thank you.
You're welcome.
Dr. Julius, I have a question for you. What is your treatment for people with chronic pain?
Hi. It's a good question, because chronic pain, pain begets muscle spasm makes more pain. Pain is a huge trigger for a need to relieve it. And one of the biggest ways to relieve it is to drink yourself numb and or take pain pills or do drugs. For people who are already on an opiate-based regimen illicitly out in the world, what we do is we bring them in and we get them stable, and we actually use Suboxone, low-dose Suboxone, frequent dosing of low-dose Suboxone to manage pain control. It's an excellent pain management, actually. Buprenorphine is 40 times stronger than morphine. I don't think people realize that. So I always tell my patients that whenever you're feeling pain through your Suboxone or your Subsolve or your Sublocade, that you need to seek medical attention, because that's significant pain since it's 40 times stronger. When given in small doses, buprenorphine will pop onto the opiate receptor and block pain control. For people that are not opiate dependent, we manage pain through modalities. I'm actually a physical therapist, so I teach meditation. We focus on exercising, trying to stop smoking so they get more blood flow to the muscles or the tissue that's damaged. We try to encourage weight loss and strengthening core muscles. I know that they do yoga at Metairie, which is awesome. I'm trying to watch the use of gabapentin, because gabapentin is being overused in the industry. It's being abused. I think the doctor will confirm that they're seeing it on autopsies, gabapentin. It's not to say that there's not a place for it, but I watch that I don't start down the gabapentin pathway. We use NSAIDs. We can use TENS units, icing, heat. I like to do a good diagnostic workup to make sure I know what's causing the pain. And then if it's out of my league, I refer out. So that's what some of the things that we're trying to do.
Thank you.
You're welcome.
Dr. Ari, you mentioned two acronyms that we'd like for you to expand on, OPC and PEC. Can you just talk about what that means?
Sure. OPC is an order for protective custody in the state of Louisiana. The coroner's offices handles orders for protective custody. So let's say a family thinks that their loved one, let's say their son, is suffering from substance use disorder, and because of that, he's either suicidal, homicidal, or gravely disabled. They go to the coroner's office. They meet with the clerk. If the clerk feels that this is a valid request, the clerk then calls up the physician for the coroner's office, who then issues an order for protective custody. The police then come to the coroner's office, get that piece of paper, and then go to that house. They have 72 hours. That piece of paper is good for 72 hours. That person is then taken against their will. Now, we got really well-trained officers, and we've got a unit that simply does nothing but that. So they know how to handle those people. That person is then taken to an emergency room. And even though there's a document that a physician has okayed saying suicidal, homicidal, or gravely disabled, the bulk of those people are not admitted. If they are admitted, they're almost immediately PEC'd. And what we're trying to do in law enforcement is, because in a sense, we started this process. We didn't, the coroner's office started the process. We want to get involved in front of it, kind of get ahead of the curve, introduce ourselves in a compassionate way to that consumer, to that family, and get involved in that treatment like a case manager would. Now, a PEC, Physician's Emergency Certificate, that's going to happen at the hospital or at a doctor's office, because that has to be done face-to-face. The physician has to be face-to-face. I guess there's some tele stuff that we can do now in some of our outlying parishes, but that's what the Physician's Emergency Certificate is. And in most cases, that Physician's Emergency Certificate moves that person from East Jeff, West Jeff, Oshner, Maine, wherever, to some other facility.
Okay, thank you. Erin, I have a question for you. So, you spoke about how Vivitrol works with the brain. Would that also mean that this is something that can be used for depression?
No, I haven't seen any research on that, and it just goes back to, we have 1,000 receptors in our brain. They all have a job. This one strictly acts on that mu receptor, which is in charge of the alcohol and opiates. I mean, the cool thing is, though, it doesn't affect any antidepressants if you're on them already. So everybody says, well, is it going to mess up this med that I'm on? I even have people that, they tell me that they're not abstinent, that they're, trying to get off alcohol, but they still use marijuana. And so they ask if that's affected. It's not. Strictly alcohol and opiates.
Okay, thank you. And one more question. What is the difference between Vivitrol and Sublocade?
Big difference. So Subutex, Suboxone, Sublocade, they are partial agonist, which means they have a little bit of a synthetic opiate in it. That's the buprenorphine. There's a place at the table for both of them. Sublocade kind of works similar. It's that long-acting, and it's not an injection, it's like a implant, I guess, and Dr. Julius can help on that. I don't know enough about Sublocade to talk about it, but Sublocade, I believe, is strictly for opiates, and I think it lasts a little bit longer than a month, and she can tag team me on this. They work similar, but Vivitrol is a complete antagonist, which means there is no opiate, no synthetic opiate at all a part of the makeup of the medication. And so I've had clients that say on Vivitrol it helps with pain, but I think the Sublocade would be better for those pain management guys, because I think the Subutex, Suboxone, Sublocade, I think it's still, like she was talking earlier, still helps a little bit with pain. So I think that would be a better candidate for some of those guys.
Thank you. Dr. Julius, do you have anything else you want to add on that comment?
Sure. Sublocade is basically Subutex in a long-acting injection formation. It is an injectable medication. It's given monthly. We numb up it's given subcutaneously right in the abdomen. They use a quadrant, start in the left lower quadrant and go around and change spots. We numb up the area and prep it out and give lidocaine before, because it is a pretty thick solution, and it actually solidifies up and makes a little walnut-sized ball. The patient can actually feel it underneath their skin, and it slowly dissipates buprenorphine over a month. It is an excellent form of medication. The person doesn't have to dose their medicine every day. They don't have to worry about storing their films. It is a pain reliever. They don't have to worry about their films being exposed to children who could get hands on to it. It's nice for patients who are going to an Oxford house or a Bridge house where, the films lying around, or having to be able to store films or count films and manage films can be a lot of work. So it's it's the new wave for trying to keep people off opiates. Probuphine is the implant that goes into the skin and underneath the skin and lasts about up to 6 months. And just to piggyback, Aaron, with some naltrexone, they are using it, trying to use naltrexone, Vivitrol with methamphetamine now. There's some studies out there with gambling. Naltrexone does help food cravings. There's a lot of versatility with that medication, believe it or not. They're trying to use it actually for the meth craze, and I'm starting to give naltrexone and Vivitrol here at Towns and at Avenues to help with meth. We'll see how it does.
Well, and I've had people tell me that even though, and this is just kind of like you just kind of got to trust clients because sometimes they teach you more than the books will. Yep. But I have a lot of meth here in Shreveport, meth clients. And so they say that usually they end up using meth by drinking first. Sure. Some people say that. And so they use Vivitrol to turn down the alcohol, which in turn turns down the meth in sense. So, but I have heard of people taking it for cravings of other things too.
That's good. Thank you.
All right, thank you. So it doesn't look like we have any more questions and we are at our time. So I want to take a moment and thank our partner for this event, Avenues Recovery Center. They saw the need and the importance to host this type of event in the community, and they were great to work with. I also want to thank our panelists who took time to not only educate us, but provide us with solutions and resources. Again, my name is Melanie Henderson and I am with Mental Health Association. My contact information will be on the next screen. So if you have any questions or would like additional resources from our panelists, please reach out to me. Thank you, and you all please stay safe in our upcoming weather that we have coming up.
Thank you.
Thank you. Bye-bye.
Bye.
Thank you.
Is it just us?
Yes.
So I saw that CEUs aren't given out to the.
It is not. We are still live, ladies and gentlemen.
Oh, okay.
You can type a question to us. Would be great.